Hi everyone, dear chair and audience. I would like to introduce my topic in dementia risk prediction. My name is Tímea Lázár, and I attend my studies as a GP resident and a PhD student. I came from Szeged Medical School, and I was always interested in psychiatry, so I joined a group of András Horváth at the Neurocognitive Research Center. My SMS is Mary Ang, and our statistician is Réka Tóth. My mission is to develop a method where we can predict dementia. So my vision looms large to anticipate a future where we can prevent all the cases of dementia before the onset of the symptoms. So we have two specific goals. In our first project, we investigate the predictive value of dementia risk scores in adults in a systematic review and a meta-analysis. And our second project is to determining the most influential components of dementia risk scores in adults with the help of AI. So to introduce my first topic, to investigating the predictive value of dementia risk score in adults, it's a meta-analysis. The project started in the previous year in September. I would like to highlight the importance of dementia. It's not only an individual problem or an emotional well-being question. It's a socio-economical question as well. According to the latest WHO data, now the prevalence of cognitive decline can reach 55 million worldwide, and by 2050 it can reach more than twice of this recent number. Fortunately, 1/3 of these dementia cases can be foreseen before of the symptoms with prevention in the early phase. Our weapon is the dementia risk scores. These are validated tools to predict dementia, the late-life dementia, based on the midlife risk factors, for example, hypertension or diabetes or eating habits. It's a really good way to prevent dementia and to perform these tests, because these are cheap and fast and simple. So, for example, we can do them in a GP consultation. Our clinical question: does dementia risk scores predict the future risk or probability of mild cognitive impairment or dementia? We examined adults free from dementia, and our factor was dementia risk scores. We investigated more scores, about 8 or 10 scores, and the outcome was MCR or dementia. So we hypothesized that dementia risk scores can predict the risk of dementia or MCI in midlife. I conducted my systematic research in 3 databases. The search key had 2 parts. The first part was a general one, and the second part contained all the risk scores we examined and the abbreviation of them. Here you can see my flowchart. Finally, we had more than 100 eligible full text, and I conducted this selection with my selection pair Esther Rodic. We have 3 types of outcome. We examined AUCs, hazard ratios and risk ratios, and we finished the analysis of the AUCs. 4 risk score had the usable data set for our investigation. Here you can see the kind risk score. Firstly, the AUC is important measurement because it can show the predictive value of the risk score at any point of sensitivity and specificity. 0.5 is the coin flip, and 0.8 considered good. Generally, we differentiate 3 types of follow-up times: long, medium, and short. The long is generally about 20 years, the medium about 10, and the short is about 5 years. Here you can see the short and medium terms are between 0.5 and 0.6, and the long follow-up times here considered good in the case of CADE score. Secondly, here you can see the Libra score. It is generally better in long term. The annual risk score has a short and medium term 1, and it is superior to the previous scores, the Libra and the CAIDA scores. And the DSI score is the best score in our examination. You have seen the outliers in these studies. The cause of the outlying studies can be the heterogeneity of the population, for example, the number of the population, or the specialty. For example, there was an article in Honolulu population. There are strengths and limitations. We are lucky because we have large data sets with long follow-up times, but these populations are really heterogeneous, and there are different types of data sets with slightly differently adjusted HRs. For conclusion, in practice, it's an easy and fast and cheap way to use. These scores can identify high-risk populations easily. And for research implication, we can find the most predictive scores. We can validate in large-scale studies new risk scores and identify more impactful components of the risk scores. We are doing the figures and tables still. Our second study is determining the most influential components of the risk scores in adults. This is a machine learning-based cohort analysis. Our clinical question, what are the most impactful components of different dementia risk scores? Here we also examine adults free from dementia. The factors will be all the components of the dementia risk scores. And outcome, the biological markers of cognitive function. We aim to do a new, better risk score than in the previous studies. We would like to do a superior risk score. So we collect all the parameters of the risk scores, for example, epidemiological parameters, medical conditions, genetics. For outcome, we get the help of the objective markers of dementia, for example, MRI results. For subgroups, we do low and high risk scores. And to make a superior risk score, we pull all the risk factors that we examined and combine them by a machine learning approach to identify the best combination of them, so we can make an early dementia prevention. To summarize, we have 2 projects, and we hope we can finish this first one in December, and the second one in the beginning of the next year. Thank you for your attention, and my so 3 for so 3 for progress, not perfection. Okay, thank you.
So first of all, thank you for the presentation. I'm sorry you had some technical issues there with the clicker. Based on the AUCs, which tool would you choose to predict dementia, and in whom? In which population?
Which tool?
Yeah, so which of the tools?
Risk score, you mean?
Exactly.
According to our recent results, the DSI score was the best in our results.
Do you know how long the DSI score has existed? Why were there no long-term follow-up results yet?
I don't know. I think it had long-term follow-ups. It had medium and long. The long generally contained 20-year follow-up times or 15, but if I'm right, it is 20.
Okay, thank you.
When we are assessing a predictor score, then we have to know also from which population the patient comes. In these papers which you selected, they were all from high-income countries, or there was a diversity? Because it would be very important if you would like to validate it.
That's a good question. Thank you very much. There was one paper that especially contained the low-income countries, and I think the Honolulu one paper is also a low-income country, so it is also heterogeneous. Fortunately and unfortunately.
But only a minor number of the papers, yes.
I think the 1/3 of the articles.
Oh, that's good. That's
yes,
good.
I think, yes.
Okay, thank you.